Hey guys, good evening. Is all set?
Good evening, sir.
Perfect. Just few simple rules of the game. We are going to have everyone on the mute mode except the panelist. So let me all introduce you all to our panelist for the day. We have with us. So fortunately, everything has happened on a very short notice, and everybody has agreed to it. We have some eminent faculty from the Association of Spine Surgeons of India, from all the zones across the country. We have Dr. Neeraj Vasavada from Gujarat, from the West Zone. Representing the North Zone from New Delhi, Dr. Gururaj Sangodimat is with us from ISIC, who's one of the pioneers in trauma surgery. We have from South two eminent faculty with us, Dr. Ranjit Unnikrishnan from Kerala and Dr. Umesh Srikanta from Karnataka. Welcome, Ranjit. Welcome, Umesh. I hope you are all around. And
hey, Vishal, how are you?
Hey, Ranjit. So we are going to have you around. And then from Maharashtra, we have Amit Sharma, who is also a consultant spine surgeon at Saifi and Prince Ali Hospital here and Wokhad Hospital. He's also going to be with us. The whole idea of having a webinar with these expert panelists and consultants with us is to have a group discussion kind of situation after we are over. We have a 20-minute talk, and after that we'll have a extensive question answer session on spinal trauma. We'll be starting in a couple of minutes. So to begin with, we will have everyone on mute mode. We will have me speaking from one side. At the same time, everybody will have the right to unmute and bring up a question. Stop the session at that point and introduce yourself and ask a specific question pertinent to that point. And the panelists will be there. You can actually ask, you can put your question specific pointing to a particular panelist, or you can have an open question where the panelists can come up to a consensus statement. And eventually we'll have some answers to it. Spine trauma, despite being one of the panelist here. Before we start, I would also like to thank Dr. Ashok Sham, who has not only taken efforts here to bring this webinar live online, and this is to take control of things around. Dr. Ashok Sham, who's running the show through OrthoTV and Bombay Spine Society, along with the panelists and OrthoTV, are going to bring up this webinar to you. And we're going to have a series of them. And most of our panelists are going to be there almost every day. As of now, we have 40 members to this, and we hope that everyone enjoys this session, which we start in a couple of minutes from now. I hope we all have the timetable for the coming week. We have spine trauma happening today. We have spinal tuberculosis happening tomorrow. Then we have Dr. V.T. Ingalhalikar coming up on Wednesday. We have spinal tumors, a 1.5 hour symposium on Tuesday, same time starting 4:45 to 6:15. Primary spinal tumors and metastatic spinal tumors by Dr. Gautam Zaveri. We have in-depth knowledge about spinal injection techniques on Wednesday. On Thursday, we'll have MIS tubular surgeries, where we're going to have all the same panelists who are all masters in MIS surgery present here. We'll be talking about tips, tricks, and techniques of tubular surgery in spine. And then we will have a session on cervical myelopathy Friday. And then Saturday, which is the 4th, there will be a slight change in timing. We'll have on Saturday a basic talk on spinal instrumentation from 12:30 till 2. We have also received some requests about sacropelvic fixation techniques, which we'll try to incorporate the same day. We are trying to get the best man on this sacropelvic fixation. We'll probably be requesting Dr. Ajay Shetty to come online and speak on his technique on sacropelvic and spinopelvic fixation techniques on Saturday from 12:30 to 2. So all days it is from 4:45 to 6:15, except on the Saturday. And the next week timetable will be releasing in the midweek next week. So we are on time and known for our time. Let me just. So we are starting over here, and today's topic is 5. So Sai, can I share my screen now?
Yes, yes.
Yeah. Some other participant is sharing the screen. So can I share mine now?
Yes, yes.
Perfect. So Gururaj, Neeraj, Umesh, Ranjit and Amit, I would request you to please keep adding upon wherever you feel I'm falling short of, and let's make it more interactive rather than a didactic lecture here.
Okay,
Sure,
Vishal.
Yeah, so I'm just bringing one case to you, everyone. Let me put this case to Gururaj. Gururaj, what is that one thing specific that you notice in this particular case, where a young guy, road traffic accident with normal neurology? Mind you, it's a normal neurology, very little compressive fracture. What is it that strikes to your mind the first thing?
First thing, actually, I want to, when there is a normal neurology, ultimately you want to see whether there is a posterior ligamentous complex injury or not, because that is what is going to decide your kind of management is going to be.
So you have already started thinking about whether this patient is going to require surgery or not. And the first thing that you think of is the posterior element injuries, right? Perfect. In this patient,
Yes.
Neeraj, can you come online there? Neeraj, a young guy with road traffic accident, very similar case scenario, almost similar looking morphology, but a complete paraplegia. Would you advise surgery in this patient or not?
Same, you mean neurology is gone, totally gone?
Yes, this patient is complete paraplegic, and the posterior ligament complex in this case is intact.
So it is intact. Yes, I still go for the surgery to stabilize and mobilize the patient early. It depends on how long the paraplegia is, whether patient is out of spinal shock, whether it is a complete spinal cord injury.
This patient is like
not,
already 2.5 weeks complete paraplegic, neglected paraplegic, more than 2 weeks old.
Well, then I think, I mean, if it is a PLC injury is not there, I think, I would consider this as a just, conservative management, because I don't think I'm going to gain anything out of surgery in this patient.
Perfect. So again, conservative treatment in a burst fracture is one option that you always keep in mind, because you feel that surgery may not add to it. Ranjit, can I have you for the third case here, where this patient with polytrauma, incomplete paraplegia, what surgical approach would you take, anterior or posterior? Ranjit, are you with us?
Vishal.
I don't think he is there.
Okay.
Vishal,
Amit?
I don't think he is there.
Yeah. Can you hear me, Vishal?
Yes, can clearly hear you.
So before we proceed further, just one comment regarding this previous case. So there is this TLICS score, thoracic lumbar injury classification and severity score. So in that, there is one very interesting thing, and it makes sense also. If the deficit is incomplete, then you are given higher score. And if the deficit is complete, you are given lower score in terms of the whether surgery is required or not. So if the deficit is complete, then your chances of requiring surgery goes down actually.
Perfect. So there are some answers. So the question is whether surgery is required or not. You have just brought up some points that there are some parameters which help us to decide whether surgery is needed or not. Right? Now,
Vishal, Gururaj.
Yes.
Because Ranjit didn't join on case 3, I just want to make one comment on case 2.
Okay.
We have to see that in case 2, if you see this case, there is more than 50% canal compromise.
Yes.
Okay. Yeah. With this kind of picture, it's usually the posterior ligamentous complex is involved.
Okay.
Usually. So you have to make sure that the posterior ligamentous complex is not involved, or there are no fractures in the posterior elements.
Okay.
All
So I
said
think,
and done.
one thing that has got overemphasized already in the first 3 slides. We are not even 3 minutes in this talk, and everybody is already clear about the fact that we are so much more concerned not about the front half of the X-ray. We are not concerned about the vertebral body fracture morphology. We are all more concerned about the posterior ligament complex. And like Amit rightly mentioned, that there are some classification systems which give some guidelines not only about the need of surgery, validation whether surgery is really going to be helpful or not. Now, my question in this case 3 is, in this case, what surgical approach would you follow? Are there any guidelines to say that no, this is the approach we should follow, or no?
Well, I think, Vishal,
Vishal.
can I come in?
Yes, Neeraj.
Okay, so I think, you said that this is a polytrauma patient, so vital structure injury would definitely take the precedence over it. So I think, if patient is medically stable, otherwise, all other vital organs are stable, then, it more or less, comes to the spine guys, to us. And if it is not, then first to just, internally brace the patient. We can just put a pedicle percutaneous screws and, hand over the patient to trauma surgeons to take care of their vital injury. Once patient is stable, vital organ injuries are ruled out, stabilized, then maybe we can go for more definitive kind of a treatment.
Perfect. So, Guru, any one thing, what approach, anterior or posterior?
Yeah.
Quick answer.
Yeah. See, whether anterior or posterior depends on whether you want to do an anterior reconstruction or not. So
Right.
that is guided by gain score.
So again, there are some parameters, some guidelines to
Yes.
say, to decide the surgical approach also. Because I'm sure in this small
Yes.
group of 40-50 people that we are here, there are anterior surgeons who will vouch that no, anterior surgery gives you better decompression. It's a patient with incomplete paraplegia, so you should decompress anteriorly. It will give you a better chance to reconstruct, because we have all studied that reconstruction and decompression both are better done anteriorly than posteriorly. However, in this patient with
Definitely.
polytrauma, posterior approach, like Neeraj justified, that you may want to think about other injuries, you may want to think about vital injuries, and then only think about what surgical approach would you want to take. Like Guru, now if you have to do a
then
posterior
Vishal,
approach, yeah.
But then we have to see here, that's an incomplete paraplegic. So one message should go clear, that canal clearance should be done as soon as possible. As soon as possible.
Right.
So whenever patient is deemed hemodynamically stable, immediately the canal clearance has to be done,
So
whether it is anterior or posterior.
Indirectly, Guru, do you imply that in a patient with complete paraplegia, canal clearance / decompression is not so important?
Yes, definitely. But in incomplete, that's the especially in a progressive neurological deficits, canal clearances really matters.
I think that brings the crux of all the questions that we are going to discuss today. Now, I will request all of us to go in mute mode. I'm going to just bring out some questions on this. Now, we just saw 3 different cases, almost looking very similar in terms of morphology. We were looking that the fracture is either 1/3 or maybe less than 1/3 in terms of the collapse. The vertebral collapse, all of them were actually looking like either a compressive fracture or a burst fracture. However, all of them were managed differently with different set of aggression. Some of them required anterior, some required posterior, some actually could have been managed by short segment, and some would have actually required a long segment like you saw in previous x-rays. Now, the questions like these always evolve in our mind. And in fact, if you're not thinking in these lines, start thinking in this line every single time you get a patient with spine fracture. Which type of fracture is this? Do I need to operate all spine fractures? Will my surgery change the outcome for these patients? What kind of instrumentation, whether a short segment fixation is good enough or a long segment is required? When do I need to surely do a long segment? and when is short segment more than enough to preserve levels. Which patients managed conservatively will go into post-traumatic kyphosis. If I have planned a surgery and a genuine indication, whether I should do an anterior, posterior, or a combined approach. Is there a role for anterior surgery anymore, or all surgeries are amenable to only by posterior approach? And if I am planning a surgery, which surgery is middle of the night emergency and which surgeries I have to do in a planned manner? To all these questions, till date, we had absolutely no guidelines. And if you ask me, is there one single article, one single chapter which mentions about answers to all these questions? There is none. However, in bits and pieces, we have answers, guidelines, and some rules to all the answers for all these questions coming up. And today we are going to discuss about them, about thoracolumbar spinal trauma. Just to bring a word of caution, the principles that we'll be discussing here are applicable to thoracolumbar spinal trauma only, not to lumbosacral, not to cervicothoracic, not to cervical, and surely not to sacral trauma. These are principles purely meant and applicable to thoracolumbar spinal trauma. Now, like Guru, Neeraj, Amit have absolutely mentioned, there is only one consensus. If you ask me, where all the panelists will bow down and come to one single point, the only definite indication for an emergency surgery in spinal trauma is deteriorating progressive neurodeficit with a demonstrable cord compromise or a cord equina syndrome. So this is the situation where you have to operate, you have to do decompression, you have to do fixation, ideally do it in the earliest timing, you should do it posteriorly, decompress and do canal clearance. So everything is clear when the indication is about a patient with progressive neurodeficit and a demonstrable cord compression. For all the other things, for all the other questions, what are the absolute other indications, when to operate, when is it an emergency, how to operate, anterior, posterior, combined, short segment, long segment, decompress or not to decompress, and if decompress, when to decompress, will my patient really improve neurologically, what is the role of salmeterol? All the other management issues are into gross dilemma. There is a huge gray zone. So everybody is right and everybody is wrong because there is no absolute guidelines. Probably by these few slides coming forward and with the presence of these expert panels around here, with question and answer sessions coming up, we'll be able to come up with some guidelines and establish some consensus at least at the end of the talk. Now, to bring some answers to the questions that we just discussed about and the dilemmas, we must understand that there have been various classification systems from time to time. Right from 1963 onwards, we have had various authors coming up with their own definitions and various classification systems to come up with answers about the question that have been posed to us from time and again. We know the definition of spinal instability. This was the first indication for surgery in spinal trauma, that whenever the spine is not able to bear the load, the structural integrity is compromised either mechanically or neurologically. This was the only indication for spine surgery. However, this was so subjective with absolutely zero objective patterns to it that almost every patient can be conserved saying there is no instability, and every other patient can be operated thinking or assuming that no, there is a presence or sense of spinal instability there. So this was one way of defining the right and rigid indications for spinal instability in patients with trauma. This is when the evolution started happening. Magrel and Dennis came up with 2-column and 3-column concept, depending upon whether the anterior column or the posterior column is injured. And Dennis, this is the time when we all started our education and we have all gone through this in the most extensive form of detail: anterior column, middle column, and posterior column. And this gave us the most simplistic classification system of spinal trauma. Not only is it simplistic, it is also very, very elaborate. It has divided fractures into 4 simple types: compression, burst, flexion distraction, and fracture dislocation, purely based on the mechanism of injury and also which part of the body is getting injured. Like this is a burst fracture where anterior and middle column is injured. That's a kind of flexion distraction injury. And the other one was fracture dislocation, where translation happens either in coronal or in sagittal plane. On one hand, this was a most comprehensive classification taking into consideration almost every single type of fracture. On the other hand, it was so simplistic that it had absolutely no guidelines coming up. So what is to be done for a compression or a burst fracture? Which burst fractures are stable and which burst fractures are unstable? How do you differentiate a simple flexion distraction from a complex flexion distraction versus the fracture dislocation? The guidelines are not clear, and absolutely no guidelines regarding the management protocols for various type of fractures were given. And this was again taken up by McAfee further classifying burst fractures into stable and unstable fractures based on the reduction of height and the kyphosis that burst fracture brought in. Also, there was a mention about chance fractures, which went into further details. Unfortunately, again, with both these classification systems, though they were simplistic, easy to remember, descriptive, comprehensive, giving complete variation about morphology of the fracture, also about the mechanism of injury, they had poor correlation with instability because they were stable burst fractures also. There was overemphasis on mechanism of injury and didn't help us to neither prognosticate nor gave us guidelines about which patients surely should be subjected to surgery, looking into the long-term prognosis, versus which ones could surely be benefited by non-surgical options. Taking consideration of these downsides, AO classification systems were into vogue. Yes, there have been further modifications to AO classifications, but to make it even more simplistic, AO came up with a most comprehensive classification system dividing the fractures into 3 different types. This was the first time when the posterior ligamentous complex was given due importance to it. Type A, type B, and type C being the different type of fractures. And to make it simple, it has only 3 types of fractures: compression fractures, where PLC is always intact. The other variant is a one where PLC is always gone, type B, distraction fractures, and type C, where PLC is gone, but with some sense of translation either in coronal or in sagittal planes. And this divided the fractures into type A, B, and C. Also, it come up with some guidelines, like type A is the fracture which happens purely because of axial loading. Of course, there are sub-variants to it. Type B is the one where distraction is the primary mode of injury. However, there is no component of translation. The 2 columns remain in contact with each other at every point in time, and there is neither a rotation, there is neither a subluxation, and there is no translation in sagittal coronal planes. And these are type B fractures. And the third variant is type C, where either a shear force or a translatory force is present, leading to some kind of translation, subluxation, or dislocation of these fractures, making them grossly unstable. Now, for the first time, AO group came up with recommendations that type A should be rarely fixed because they are usually inherently stable, and type B should be only rarely fixed when you feel that there is a distraction which is complete, and type C is the most unstable variant, giving a complete fixation recommendation for these cases. Like in this particular scenario where there is a wedge compression or a mild burst without neurology. Type B, where there is a distraction injury, the posterior tension band is gone, there was a recommendation of fixation. And type B, again, this is the most important variant where there is a complete disruption of posterior ligamentous complex with or without neurology. Usually the recommendation is to fix them. And type C, whenever you see a translation, dislocation, subluxation, always fix them. This was the first time that AO came up with some guidelines. However, they were vague and the answers to many other questions were not given. This was way back in 2001. The disadvantages being this: at this time, the AO group had no mention about neurology. 2013 was the first time when AO not only took A, B, C of fractures into classification, but also added an N factor to it and various type of N factors, N0 to N5, depending on how bad the neurology is involved, was included, making it further a comprehensive classification system, which we are going to discuss very soon. On one hand, it was too descriptive. It did not consider neurology at that time. PLC, though it was given due importance, however, there was a gross variance in the type when you describe how PLC could be injured, and there was no objectification of PLC injury. And all these pointers were further taken into consideration by Vaccaro et al. In 2006 when it came up with TLICS classification. Till date, this is one of the most comprehensive classification, one of the one which has been validated time and again. Of course, there are recent controversies about whether it is validated to pediatric systems or not, whether it is really available in burst fractures or not. And I'm sure Guru from ISIC, they have had a study on questioning the validation of not only load sharing, but also about TLICS classification. We'll come back to Guru on this and asking some questions on it. Now, coming to TLICS classification, how is this the most comprehensive classification? Is that it not only takes into consideration the morphology, which Dennis gave across. Now, Dennis classification gave morphology as compression, burst fracture, distraction, and dislocation. All the 4 variants were considered into this. Magrel's and AO concept of PLC injury was included into this, and this was the first time that complete definition of when to call a PLC injury to be a complete injury versus an indeterminate injury versus a non-injured PLC was defined and pointers given to it. And then the neurology in the form of complete, incomplete, or root injury was also defined. Based on the morphology, PLC, and neurology, every point had a pointer. So compression had the least points, whereas dislocation had the largest point of 4 points. posterior ligamentous injury, when it is interrupted or disrupted, it had the highest points, whereas when it is intact, had 0 points. And neurology, when it is complete neurology, like Amit mentioned at the beginning of the talk, whenever there is a complete neurology, the need of surgery is further mitigated, telling that the surgery may not be of great benefit, at least neurologically, unless there are various other pointers to define the surgery. And complete neurology in TLICS classification has 0, incomplete has the largest points, root injury has another pointing system. And based on this, 3, 2, 1 or 0 points are given, and if the points are more than 8, forgive me for 7, if it is more than 8, surgery is recommended irrespective of the status of morphology or neurology. It's a complete comprehensive status. Like in this case scenario where we started in the first case, like Dr. Guru mentioned, surgery is required. Why is surgery required? Because this was the first time that it was validated that if these patients, where though it looks like a compression fracture in Dennis classification, in AO classification, it looks like a type A injury. In MRI, it shows that there is a PLC injury, and that's why it gets highest points. And this makes it a strict indication for surgery, because even with neurology normal, this is the strict indication for surgery, if not resulting into post-traumatic kyphosis. Coming to another case scenario, our case 2, where we started, a burst fracture with complete paraplegia. Like Dr. Neeraj mentioned, you may want to do surgery, but not for neurological reasons. If this patient comes to you with complete paraplegia, a burst morphology, complete neurology, your TLICS classification gives its points less than 6, and this is the one which can be managed conservatively, and surgery is not absolutely indicated. Whereas in another case scenario where there is incomplete paraplegia, burst, distraction injury, PLC is ruptured, incomplete injury, all the pointers giving you more than 8 points, making it a strict indication for surgery. So whether to do surgery or not, now there is a clear-cut guideline when to conserve, which fractures to conserve, and which fractures should surely be subjected to surgery. Based on this TLICS classification, this is the most comprehensive, giving you an indication of when to do surgery and when not to do surgery. And it has been shown that there is excellent validation to prognosis, that patients which do not require surgery can easily be managed conservatively, and patients with neurology and morphology can be easily validated to surgical requirement in these patients. So Guru, let me just stop here for a small while we are discussing TLICS classification, and let me have you on board to tell us about what concerns have come across with TLICS classification currently.
Can you hear me, Vishal?
Yes, yes.
Yeah, see, actually, TLICS classification, the main problem was the inter and intra-observer reliability, especially regarding the posterior ligamentous complex injury. So when we did this study, basically an ideal classification should be reproducible, and it should be reproducible to such an extent that the junior most colleague in the team should clearly able to specify it. So with the TLICS, the major drawback was the classification, the score given in PLC, because there was a lot of importance was given to posterior ligamentous complex. So the score given in posterior ligamentous complex was not very reliable, because to decide whether the PLC injury is there or not, you need MRI always. And in MRI also, sometimes it can be indeterminate. So that was one of the main concerns.
Right.
Vishal. Yeah. So that was one of the main concerns.
Right. What other concerns have been raised lately?
And then the other concern which was raised was about, there are two schools of thought about complete and incomplete injury.
Right.
The one concern is whenever we examine these patients in our emergencies, if we classify them as complete injuries,
right,
that is not the right scoring system actually. Whether the patient was complete or incomplete at the site of the accident, that becomes very important.
Right.
Because the secondary injuries which happen.
It's very important what Guru has just mentioned, and I was just searching for an article. This is one article that I'm going to show you. Can you all see this article on the screen?
Yes.
Am I able to share my screen there?
Yes, we can see that.
Yes,
Yes,
yes.
yes,
Yes,
Avita,
yes,
we
we
can
can
So
see.
this is one article that I would want you all to go through. This is one article which not only tells you about the pros of reliability, but also what Guru just mentioned. There has been a major concern about definition of posterior ligamentous complex injury. And this is one article that I'll probably share with one of the guys who will share with all of you, where Vaccaro himself has come up with his concerns on how to really assess a PLC injury. So this is that one article that you may want to read about. And then there is a concern about, in fact, I'll just come up with the answer that MRI is not as sensitive and as specific in determining the PLC injury, because sometimes it may not pick up subtle PLC injuries and sometimes it may over pick up PLC injuries. A mild edema doesn't necessarily always mean that the PLC is disrupted. And at the same time, sometimes facet injuries may be missed, capsular disruptions may be missed. And that is why not only MRI, but a CT scan also is absolutely must in determining whether these patients have a PLC ruptured or not. So that is one concern that has come forward and it is being further evaluated. And this concern has been now taken up by AO classification. At the end of this talk, I'll probably share the article of AO classification also. In fact, since we are here, I'll just go there and show you the AO classification also. So that is my concern number one that has come across. The other concern that has come is, like Guru just mentioned, how do we differentiate and which patients do we call complete injury versus a incomplete injury? I'll just show you one of my article that I have just kept all for you guys. So this is one classification system, A, B, and C they have used, and AO classification. Now this has come in 2013, which not only takes into consideration the type morphology, A, B, and C, if you can see that. And for the first time, 2013, the neurology was also taken into consideration, mentioning about 0 being neurologically intact, N1 being transient deficit, and N4 being complete deficit. Now the problem lies in evaluation of these patients in emergency room. Let me take a show of hand. How many of us in our examination room or emergency room genuinely go and do a PR for all trauma patients? How many of us? Be very open and be very frank to yourself. We can easily fool each other, but frankly, ask me, very few of us would be true to yourself.
I do it regularly.
Very few actually would be telling in your heart that actually you have been doing it. You have been doing it. So I would tell you that very few of us do it, and that's the truth of it. In fact, there was a survey to ask how many of us actually do a PR examination to assess whether complete or incomplete injury is found in these patients, because that is one marker which will decide how much score the TLICS is going to give you across. And that is why it is very,
Not
very
only
important.
PR, Vishal. Not only PR. We need to do a bulbocavernous reflex also.
Exactly.
To rule out there is a spinal shock is over. So that is also very important.
Exactly. So I think the message is very clear. Whenever a patient comes to you in ER or any spine trauma patient on any given day he comes to you, first and foremost is not only to look at the X-ray of the patient, try to get a CT scan of the patient also, try to have a MRI scan, assess the PLC first. And the subtlest form of PLC injury you can easily pick up on a X-ray is by not only interpedicular distance increase, interspinous increase. And now there is a rule that X-ray should not be seen from the front of the vertebral body to the back, but from the back in the interspinous area to the front, because the morphology of fracture in the vertebral column is not so important in decision making, but it is in the interspinous area. It is the PLC integrity which decides. If the patient has incomplete injury, there is no doubt that this is a surgical emergency. You do not have to wait for anything. Don't wait for a CT scan. Don't wait for MRI. Start planning for a surgery, and middle of the night of the surgery is the call of the day. If the patient has a complete injury, do a complete neurological examination to ascertain that you are dealing with a complete or a hidden incomplete injury in front of you. And if you find that it is a complete injury, then the question of PLC versus a morphology, or even in patient with no neurology. So if a patient comes to you with zero neurology, absolutely normal neurology, again in those patients the morphology and the PLC is the one that takes into picture whether surgery is required or not. Are we clear there? Shall we proceed there?
Vishal, can I intervene?
Please, please.
Vishal?
Yes, we are.
One thing we have to be very cautious when labeling complete injuries. We have to be very clear with the history at the site of the accident, whether there was any slightest of movement or any slightest of sensation was present or not.
Very important.
If at the site of the accident, if at the site of the accident, if there was any slightest of sensation or slightest of movement was present, for all practical reasons, those patients have to be taken as incomplete injuries.
Very valid point. Very extremely valid point, that right from the time of injury to the patient reporting in the emergency, if at any given point in time there was even subtlest neurology present and the movements have led to worsening of neurology, it has to be considered as an incomplete injury followed by a secondary injury which is reversible in nature, and surgical decompression is going to alter the neurological course of the patient. This history taking is extremely important and a very, very valid point. Thank you, Guru. Now we have Umesh also with us. Umesh, would you like to add something to this? Like, how differently do you evaluate your patients in emergency room apart from clinical history taking, evaluation of complete versus incomplete, and what investigations are a routine in your practice? Umesh, you may want to unmute yourself.
Yeah, can you hear me now?
Yes, clearly.
Yeah, so I don't think it's anything different that we do than what has been discussed all this time. So basically, it would comprise of a initial evaluation by the ER physicians, of course, in our hospital, and we come into the picture only after all the investigations have been done, and it's all ready on a platter for us to decide what is the next plan of action. So when we see the patient, actually by this time the investigations have already been done, the patient has already been stabilized. I am sure that most of the time, most of your hospital also, it is the same.
That's right.
So, yeah, so based on the imaging and the clinical picture, then we decide what is the next appropriate management protocol in these cases. So I'm sure most of those points have already been covered.
Right. So I think A, B, C is we all know about. We have taken care of A, B, and C. History taking in the ER to understand if there was any bit of neurology present right from the time of extrication to reporting in ER. Evaluation of neurological status is extremely, extremely important because that can change the whole game and the surgical planning. And the question whether this patient requires emergent surgery or a planned surgery depends only on one thing: whether this patient has an incomplete neurology right now or has a complete neurology or no neurology. If the patient has incomplete neurology, straight away plan for a surgery. If the patient has a complete neurology or no neurology, that's when you start evaluating this patient for further need of surgery versus conservative treatment. And need of surgery now, whether surgery is required or not, can be clearly established by various guidelines laid by various classification systems. AO is one among them. 2013 is the most recent update in the AO version where morphology, neurology, PLC, and everything has been taken into consideration. TLICS laid the foundation of modern classification systems way back in 2006, which is again a comprehensive classification giving answer to the basic question whether surgery is required in a patient with spinal trauma with complete neurology or with no neurology at all or not. Now, if you have an answer to this, that you have to do a surgery or not, the question is whether you may want to do it anterior or posterior still remains. Like in this particular patient, should we do a surgery anteriorly or should we do a surgery posteriorly? The answer is still not given neither by AO classification and has still not been given by TLICS classification. And the answer to this comes forward from load sharing classification. So on one hand, AO has given the answer when to do surgery. TLICS has given an answer when to do surgery in a patient with normal neurology. Load sharing classification also has been giving answers to when to do a surgery anteriorly and also when short segment surgery will surely fail. So if you ask me which burst fracture you may want to do a long segment fixation and which burst fracture you may want to do a short segment fixation, you get an answer only from one classification, which is load sharing classification. In a patient with normal neurology or complete neurology, which patient surely would do a surgery anteriorly? Again, the answer comes from load sharing classification. And this classification system purely divides the anterior half, the fractured vertebral body, into three components. It assesses into three formats. The simplest thing that it assesses is how badly is the fracture comminuted, because that will decide whether this fracture will go into union or will go into a non-union, or if it even unites, whether it's going to unite in same place or it will collapse while uniting. The second is the amount of kyphosis at the time of presentation. And the third is the spread of the fragments. And all these findings have to be assessed on CT scan. So this assessment is not done on an X-ray. And that is why load sharing classification, which takes findings of comminution, spread of fragments, and initial kyphosis on the day of presentation, is something that mentions about whether surgery is required or not in a stable burst fracture. And if surgery is required, whether anterior reconstruction is required or not. Now, mind you, anterior reconstruction doesn't mean the anterior approach through thoracotomy or thoracolumbar approach or a retroperitoneal approach. You can do anterior reconstruction from behind through extensile approaches also. The question here is whether anterior column reconstruction by whatever approach is mandatory or not. This question comes to you from load sharing classification. Probably at the end of the talk, I'll share the article which I've just kept with me. Dr. Sai or one of us will share the article with all the participants of the course here. Now, again, load sharing classification on one hand gives multiple answers. It is extremely difficult to validate it in multiple studies. It has been found to be literally controversial. Again, let me get back to Ranjit and Guru on this. So, Guru, I think Dr. Chabra has some study and he has raised a valid point of questioning the validity of load sharing. Can you highlight the credibility of load sharing classification for us? We are. You may want to unmute, Guru. You may want to unmute at this time.
Okay. Basically, the study was not on load sharing classification. It was mainly Dennis TLICS and the old AO classification. But then what the limitation with the load sharing classification is, that's applicable only to the thoracolumbar junction.
Right.
And this load sharing classification came before the intermediate screw or a screw in the fracture segment, fractured vertebra was devised. So this load sharing classification needs to be modified after this index screwing came, that is the intermediate screw fixation has come up.
Exactly.
So the guidances for long segment fixation, short segment fixation, really based on load sharing classification with advent of intermediate screw fixation doesn't really hold good right now.
That's right.
But still, like right now, like you told, whether it needs an anterior reconstruction or not, a load sharing classification gives a good amount of idea, but it has to be individualized based upon the neurological deficits also.
So Ranjit, let me take it for Ranjit now. I think you are with us. Ranjit, are you there? Can you unmute and come on for us, please?
Hi, Vishal, can you hear me?
Yeah, very clearly. So Ranjit, one quick question. In a burst fracture, which fractures would you use a fracture screw, interfragmentary screw, and which fractures would you surely do a anterior reconstruction? Like all posterior versus anterior reconstruction. Like I sometimes put a screw in the pedicle of the fractured segment in a burst fracture. Sometimes I do reconstruction. Do you follow some specific guideline, any classification that guides you through?
Yeah, so my thoughts are in line with what all was discussed right now. The decision, when you come to a burst fracture and apart from a surgical decision, when you go for the thing which you raise, anterior versus posterior, what I understand is that the entire gist of the treatment is an understanding, will the anterior column heal or not? We all know that if the anterior column does not heal or does not have the capacity to heal, our posterior segment will fail because we are going to fix with a gap in the front. So the only way in these situations to know whether the anterior column will heal or not is by the load sharing classification. That's the only guideline which we have to tell us that how much or what is the probability that it is going to heal without a direct intervention. Mind you, by direct I mean doing an anterior reconstruction. So
Right.
today I think it's fairly standard for all of us to put a screw at the fractured vertebra. Now, by doing that, we are expecting that the anterior column will heal, and thus we will not have significant kyphosis progression. So apart from what you mentioned that about imaging and going for surgery, I personally would like to always have an image before I decide, even if at the night or wherever you have a progressive deficit, I want to have enough information before I go inside for surgery or not. And it becomes mandatory in these kind of burst situations to have a CT scan of at least that level to help you decide on the anterior column reconstruction. If contrary to what we think, most of the osteoporotic fractures or the not so-called good bones are where we might have to do something anteriorly for the anterior and middle column. This could be done from the back or from the front based on your expertise and your facility availability. But
Thank you, Ranjit. Very valid point. I think we all now understand this. Let me just rephrase everything here for all of you. We are dealing with only two types of fractures when it comes to thoracolumbar spinal trauma. One with incomplete injuries. Those are not the ones where any question arises. Incomplete injuries, the dictum is clear. Posterior surgery, emergent surgery, early decompression, long segment stabilization. The better you do decompression, the better the neurological recovery is known to happen. And incomplete versus complete has to be established by history taking and examination. The second part of fractures are one where neurology is either completely intact or is complete paraplegics. These are the ones where you decide whether surgery is to be done or not purely based on mechanical grounds. And what are the mechanical grounds that you look for? Question one, Ranjit posed the valid question, whether this fracture will heal itself in natural course or not, whether this fracture is prone to develop post-traumatic kyphosis or not, and three, whether this is the patient where whatever need the surgery comes across, will the implant be stable or not. Now, if this fracture is supposed to heal, whether it will heal or not, how do we objectify it? Load sharing classification helps you. The PLC injury and load sharing both tell you whether this patient will go into traumatic kyphosis or not. If this patient has a PLC ruptured, this patient is highly prone to develop post-traumatic kyphosis. If this patient has a anterior column comminution more than 30-degree kyphosis and a spread of fragments more than what is mentioned load sharing, again, despite having a PLC intact, the chances of post-traumatic kyphosis are very, very high. And these patients will have a failure of implant if anterior reconstruction is not done. Neeraj, let me come back to you. Neeraj, when do you in your practice put fragmentary screws? Like, what are the situations when you would not put a interfragment screw, like a fracture segment screw? In a burst fracture, burst fracture D12, PLC is intact. Would you do one level above below with anterior reconstruction, or would you do a one level above below with a fragment fracture fragment screw?
Well, as I think, as Ranjit rightly said, first we need to assess whether that fracture is going to heal without doing any anterior reconstruction or not. If we need to do an anterior reconstruction by, putting cage, there is no question of putting the index level screw. But if a patient, the fracture is likely to heal, it says load sharing classification score is appropriate for only posterior surgery, then I think I would go one level above, one level below an interfrac screw. That's all.
Interfrac screw. And when do you
the index level?
Yeah,
index level screw. Yeah.
Yes, Ranjit, when would you refrain from putting an index level screw and surely do an anterior reconstruction?
So if my load sharing classification tells me that it is not going to heal and there is severe comminution, if you see the CT scans of these burst fractures, when we will always find that one of the pedicles are attached to the part of the body or a large fragment of the body. In the ones in which there is no contact, I will not put a screw because it's not going to help me at all.
So very, very, very well said. I think let me just summarize it here again. Interfrag or index level screws are not to be used in patients where load sharing classification is against the fact that fracture is not going to heal, number one. Number two, if there is a pedicle fracture, if the burst is so wide that your screw is only going to put the retropulse fragment behind, You should not use the interfrac screw, and anterior reconstruction in these patients is important rather than doing a short segment fixation. And this again has to be taken into consideration in a tailor-make manner. Now the downside, like Guru mentioned,
Vishal.
Yes, Guru.
Vishal, and the other thing is, so we have to see the patient, basically fracture morphology in the X-ray and after positioning.
Exactly.
If after positioning, if you see that the body height is getting reconstructed, or if the body height was 50% and then it is getting reconstructed to maybe 80%, 90%, then there is a high chance of collapse. And then
True.
there was a preoperatively there was a lot of kyphosis. So then
Right.
there's again high chance of collapse. So
Exactly.
these are again special situations where you need a index screw or an anterior reconstruction.
In fact,
And then
yes.
And then the other thing what we have to see is the concept of ligamentotaxis is absolute now. So we shouldn't be distracting we shouldn't be distracting these fractures. We should be compressing on them and then try to achieve normal anatomy as much as possible. Don't leave a fixation in kyphosis.
Very true. Very, very valid point. Please do not distract these fractures in an attempt to get better height. The more you distract these patients intraoperatively, the more chances of collapse. In fact, you can preemptively say which fracture is going to collapse, which short segment fusion or even a long segment implant is going to fail. You can exactly know the moment you have positioned the patient. And just to make it sure, in fact, there has been a recommendation that in a neurologically intact patient, rather than operating on day 1, 2, or 3, wait and conserve them for a while and do a standing X-ray at 2 weeks or 3 weeks time. If you see a significant movement at the fracture site, you know that this fracture is surely going to go into post-traumatic kyphosis. And if there is a significant collapse on a standing X-ray, you know that you will want to do an anterior reconstruction and surely not distract. Otherwise, these implants are going to fail more often than not. So I think we are all on a common page here. And the questions we started with in the beginning of the presentation was when to do surgery in a patient with complete neurology, when to do surgery in a patient with intact neurology. We now have answers to it. When to do anterior reconstruction mandatorily, we now have answers to this. When does short segment fusion in trauma fail? We now have answers to this. Just to bring in some common case scenarios here. Like in this patient, we now, just by load sharing classification, otherwise it would have looked a simple, on an X-ray it looks like a simple burst fracture with no neurodeficit. However, with load sharing classification coming into picture, you see more than 2 millimeter comminution spread, you see more than 50% collapse, you see more than 50% of the vertebral body comminuted. You now know that this is a patient who's surely going to go into a post-traumatic kyphosis, and by either conservative means or by a short segment instrumentation without anterior reconstruction, the implant is going to fail. And this is what was done in this patient. Now, we exactly know when to operate, whom to operate. The indications of surgery are clear. Now, the biggest question is how urgent do we operate? So, Ranjit, a burst fracture with complete neurology, how urgent do you operate these patients?
Burst with complete neurology.
Yes.
Now, imaging telling it is not a cord transaction. Not a cord transaction. So in which case I will operate at the earliest available time. Not necessarily at the middle of the night. At the earliest available time, I try to take it as early as possible.
Like planned procedure tomorrow, next day morning?
Next day morning, first case.
Yeah, but not like middle of night?
No, not in the middle of night.
Neeraj, in your practice, what are the middle of night procedures in spinal trauma?
I think only progressive neurological deficits.
Okay.
If patient comes with incomplete spinal injury or a normal neurology and it deteriorates while patient is admitted, then I think I'll immediately go inside the theater.
I think this
Otherwise,
is something
I think
that,
morning first case.
Agreed. Thank you, Neeraj. I think this is something that we all across the board agree that the most important emergent indication for surgery in thoracolumbar trauma is a progressive neurodeficit, incomplete neurodeficit. or a traumatic cauda equina syndrome, you know that you can change the course of time. Middle of the night surgeries are absolutely validated, but it doesn't mean that you are not prepared. Of course, you have to be prepared for it. You don't want to do more damage to the patient. Guru, anything in relation to polytrauma, like a patient with multiple injuries with spine fracture, no neurology? Would you want to do stabilization middle of the night, or you will want to wait till the next day?
No neurology, you mean intact neurology, right?
Yeah, so now we know that incomplete neurology surgery is required. What are the other indications where middle of the night surgery you may want to do, like an emergency surgery? Medico-legally, it's absolute must to do.
I don't think there is anything else where it requires a middle of the night surgery. Because in polytrauma, basically the hemodynamic stability takes precedence over anything other than any fixation, basically. So if there is a spine fracture with the long bone fractures with intact neurology, long bones take precedence over the spine fracture. So
understood.
Definitely there is nothing other than progressive neurology which requires middle of night surgery.
Right. I think the message is very,
Vishal,
very
Vishal,
yes, Neeraj.
Vishal, one thing, I mean, in polytrauma kind of a patient, I mean, if other colleagues, say the GI surgeon or somebody is already taking patient for surgery in the middle of the night, yes, I would want to jump in and just put a percutaneous screw so that, I mean, I might presume that patient might not be coming back to my OT very soon.
Thanks,
so just
Neeraj,
want to stabilize that.
Thanks, Neeraj. It's a absolutely valid point to take into consideration. Damage control orthopedics, you are valid to do it and medico-legally responsible for things after the patient is admitted to hospital. So if the patient is hemodynamically stable or is being taken up for surgery by some other team for some reason, doing a percutaneous stabilization to prevent a secondary injury to the cord is absolutely a extended indication for a middle of night surgery. Also, the third thing where I would recommend doing a middle of night surgery is a fracture dislocation of the spine, where you know that the column is grossly unstable and can result into life-threatening disorder. Vascular injuries can come across. I think fracture dislocation, cauda equina syndromes, and polytrauma patients for damage control orthopedic surgery is something that you may want to think about emergency surgery. For all the other things, whether it's a burst fracture with complete neurology, PLC injured, worst load sharing scores, worst TLICS scores, worst AO scores, if the other preceding incidents are not compelling enough, these all cases have to be done in a planned manner, and there is absolutely no need to rush in. Your surgery is not going to change absolutely anything if you are doing it in a planned manner versus the emergent manner. So the indications for emergency surgery, when should you do the surgery, is pretty well defined. You should not burn out yourself in doing every trauma patient the middle of night surgery. You may actually do more harm than anything. And indications for surgery are defined. The timing of surgery in spinal trauma is very, very clearly mentioned and defined already. Ranjit, anything you may want to add to this regarding indications and trauma?
Nothing. Very much in line with what you said.
Now, before we go on to how to operate, let me just grill upon our panelists today on when do you conserve a patient of spinal trauma? Like indications of conservative treatment in your practice. Ranjit, let me start with you.
Yeah.
And so that Ranjit, so that you don't fool across me or anyone else, I'm just getting some article here as well upon conservative treatment.
Okay. So to me, before I conserve a fracture, it's mandatory for me to have maximum information about the injury. Meaning I might have an X-ray, which I always have. I might have an MRI and a CT, and then decide to conserve. Because remember, the moment you conserve a fracture as per guidelines, you have to have maximum information that you're conserving. The last thing you want is you conserve a patient of thoracolumbar burst fracture. He develops a kyphosis and comes back to you, blames you for conserving it. So it's
absolutely valid. But Ranjit, let me just summarize this for everyone. You have to make sure that this patient is not going to develop post-traumatic kyphosis in a patient in whom you are thinking to conserve. Number one. Yes. What else do you take into consideration?
So in this respect, what you mentioned in your first part of your talk, PLC injury assessment. So like what you rightly mentioned, even Dr. Vakara has published, the PLC assessment is very subjective and objective. You might
just to bring out this article for everyone, evaluation of PLC injury on MRIs. There is a major problem here. If you can just go through this article, injury of PLC on MRI imaging, the sensitivity and specificity of MRI to diagnose PLC is lower than previously reported. And this article is by none other than Vaccaro, 3 years after he came up with his classification, further questioning his own articles, saying that multiple injuries may get missed. So
Exactly.
what we actually see, this is like a overseeing on MRI and this is like a underseeing on MRI. But what Ranjit is mentioning is very important. Before you plan to do a conservative treatment, assessment of PLC injury is very important. Yes.
So I think we should, what I look at is I look at indirect markers of a significant PLC injury, like widening of the facets, facetal rotary failures, large interspinous widening on the lateral CT film. These are the things which might tell you that this patient might have a significant PLC injury. Also, the MRI especially might overestimate the PLC injury. So look at the stir images for more specificity.
Right.
So this is what you should not be in a mindset that, oh, I took a CT and an MRI and an X-ray and I'm saying them no surgery. No, because all this has to be documented before you conserve, and also tell them that even with all this, you might have a progression of your kyphosis, but it might not be affecting your daily life.
Right. Now coming to Guru. Guru, can I catch you on, in a completely neurologically paraplegic patient, complete neurological injury, non-surgical, role of non-surgical treatment. You come from the largest center where non-surgical rehab is the so non-surgical treatment in a patient with complete paraplegia, when to do and when not.
Okay, so when there is a neurological involvement, it's usually there are two kind of instabilities. That is, one is morphological instability, then another one is neurological instability. So when it comes to a complete neurological deficits, usually surgery is preferred in developing world scenario like India, because we don't have a manpower and an infrastructure to manage them conservatively and rehabilitate them. So from the stroke mandible, which is a mecca for spinal cord injury management, they do conserve most of their complete spinal cord injuries and rehabilitate them simultaneously. But then in developing scenario like India, we don't have facilities to do that. So most of these patients require at least a fixation surgery so that we start rehabilitating them early. So the indication for surgery in complete spinal cord injury in Indian scenario is to start early rehabilitation.
Right, right. So, but are there scenarios in patients with complete neurology with a stable burst fracture where people can still allow the fracture to heal over a period of time and then start rehab?
So you lose a lot of precious time in waiting for the fracture to heal.
So
the
only,
first 6 weeks is the
when
very
you have an aggressive rehab unit, do you recommend that you would want to stabilize them and put them into aggressive rehab?
Not only, it is mandatory that every spinal cord injury patient should undergo aggressive rehabilitation.
So what are the
But
role
then
of
if you think, if you
conservative
don't,
treatment?
for in a complete neurologically injured patient, if the fracture is absolutely stable and you can mobilize them the next day, which is very, very unlikely. This is very hypothetical scenario, which is very, very unlikely that patient is absolutely fracture is absolutely stable and patient has a complete neurological deficit.
Exactly.
So in that scenario, you can easily conserve and rehabilitate them. This can happen in children where we have a real shivara, not shivara. It's real shivara. There, the vertebral column is stable. Still, patients have a neurological deficits. There, you can conserve them, equally rehabilitate them. But then, in other than that, it is very impossible.
Right. So just to bring out the Guru's point here, in a study done from 2010 to 2016, where they actually found that neurologically intact patients with bad fractures, there are only 20 such patients they were able to find in 7 years. So it's an extremely rare situation when a patient is completely neurologically involved and the fracture is simple and the fracture is stable and the fracture is morphologically the one which will heal by itself. And that is why what Ranjit just mentioned is evaluation of fracture clinically and evaluation of neurology clinically is radiologically and clinically is extremely important. And unless until a complete clinical examination of neurology is done, complete evaluation radiologically of fracture is done, you should not come to a conclusion on which fracture will do better conservatively or surgically. However, if you have evaluated and known that this patient has a stable fracture with or without complete neurology, conservative treatment does have a role to play. And in fact, what is said that over a long-term period, radiographic outcomes may look better in surgical patients. However, clinical outcomes are absolutely same, and the clinical outcome is better decided by the rehab of the patient, for which if you feel that your rehab is going to be complemented by fixation surgery, that is the only reason when surgery will be required. Otherwise, this is one article that will really impress upon you. This is a very wonderful article. Everybody should go through this. So,
but Vishal, one thing is sure, Vishal.
Yes.
The conservative management in a complete spinal cord is more difficult and more expensive doing surgery.
That's right. That's right.
This is clear when it's to developing world scenario.
That's true. That's true. So in fact,
because
now
a conservative management will involve a lot of complications.
That's true. That's true. So I think now we have established absolutely clearly the guidelines of when to do surgery, what is the real justification of your surgery medical legally also, what is the need of surgery, when should you time your surgery, what are the cases where emergency surgery is absolutely required, what are the cases where you can do a planned surgery, what are the cases where your surgery is to be done as a damage control orthopedics as a supplement to other things, and when would you want to do surgery like an emergency situation in a patient with incomplete neurology. There are all these classifications. They are only meant to drive some answers for the question that we have come across. And the most important question that comes to our mind is how to operate. Anterior surgery, posterior surgery, or a combined surgery. Umesh, in your practice in last 5 years, how often have you done an anterior approach, either a thoracotomy or a retroperitoneal approach for a trauma patient? Umesh.
Yeah. So Vishal, yeah. So very few. And most of them were actually in the earlier stage where we were probably more aggressive, and we thought that these kind of fractures need an aggressive anterior management with a large cage, so that we can limit the number of levels posteriorly. So probably that was one of the reasons why we went anterior. But more and more as we have evolved, now most of our surgeries are from posterior. So even if an anterior reconstruction is required, it could be done from a posterior itself. Though the size of the cage, the stability that, the size of the anterior cage that we could use from a posterolateral approach is much, much smaller than what we could have put with an anterior approach. So that the cage size, we could really put a large cage from a lateral approach. So in recent times, one of the main reasons why we have gone anterior is in revision surgeries, where patients have undergone like limited single short segment fixations for a traumatic burst fractures or something like that, and they have developed a progressive collapse later on, and they present to us with screw loosening and progressive kyphosis. So in those cases, rather than going through a previously operated laminectomy defect and going posterolateral where there is a lot of adhesion, so we feel it is more simpler and more easier to go with a lateral approach or in those cases, and where we can easily give a sufficient anterior support without going through that posterior scar tissue. So that is one of the reasons what we have found in recent times, and where it is still valid. And I think that is one main indication for us to go lateral approaches, even though we are quite proficient in a posterior or posterolateral anterior column reconstructions.
Very valid point. Very, very valid point, Umesh. Thank you for bringing this out in a revision case scenario. Amit, let me catch you on this. Amit, you coming from one of the institutes which is like the mecca of anterior surgeries, KEM Hospital. Are you not like hellbound to say that anterior surgeries are known to do better reconstructions and anterior surgeries are known to give us better decompressions also? Then what is your take on that? Amit? You may want to unmute yourself, Amit.
Yeah. Can you hear me now?
Yes, clearly.
So during residency, I had seen many of these anterior surgeries. not only for tuberculosis, but for the trauma as well. But in my practice, what I found, I totally agree with Umesh that I don't remember even a single case. Unfortunately, I did not have a revision scenario. But in the primary situation, in the thoracolumbar area, definitely it's never had to go anterior. And even if you have to remove one complete vertebra wherein you are removing one disc above and one below, so you may be putting a cage of a size of maybe 2 inches long or maybe a little more. And I think you are able to accommodate that very nicely just by going from behind.
That's
now,
right.
That's right. Yeah, for that matter, like in some situation, even L5 we have replaced like the entire body from behind. But just considering if you talk about the thoracolumbar area only, I never had any issue to reconstruct even the entire vertebra and the disc above and below just by going posterior.
Neeraj, one indication where you would not be able to do the surgery unless you do it anteriorly.
One? Come again, I could not hear you.
One indication where anterior surgery is must. Like you cannot do it only posteriorly.
So when, you have a complete burst, you want to reconstruct anteriorly, you'll have to go anteriorly. Is that what you want to say?
Yeah. So, or like Umesh says that you can easily reconstruct up to one vertebral body from behind.
So maybe, maybe you have, two adjacent body fracture along with a disc injury as well. That's a highly unstable injury, and you will have to reconstruct. So ultimately it comes to load sharing classification only, that when you feel that you are not going to heal fracture by your only posterior means, then you will have to absolutely go anterior.
Right. I think we have discussed almost all the aspects about need of anterior surgery. When is anterior surgery required? Yes.
Vishal, there's one scenario where you might need to do anterior, where you need a bigger cage size, is osteoporosis.
Right. Also, I feel in lumbar spine, if you're dealing with a L4 or a L3 vertebrae, getting anything more than 15 millimeter cage inside from behind is not going to be an easy task unless you handle or severe your nerve roots there, which is really going to be a challenge. So that is one place where I think anterior surgeries are better.
You can do two things over there.
Amit, can we hear you, Amit?
Yeah, you can do two things, two changes here. You can put an expandable cage, which will be easier to go, then you can expand it. And secondly, you can put the cage from both the sides. So you are, rather than one cage, you are putting two cages, smaller diameter, rather than one big cage. So I think that will serve the purpose.
Amazing technical tip. I think this is the tip of the day for all the surgeons who do spinal trauma very often, using a smaller diameter cage, because always the fear is that in a lumbar spine, if you put a smaller footprint of the cage, it will sink in. And so putting in two cages from both sides of small diameter, expandable versions, expanding them can really be of great help. The only challenge is that the longer the expansion that you utilize an expandable cage, the chances of you having pseudoarthrosis and cage subsidence is very high, further posing a damage of implant failure. And that is why if you can do anterior reconstruction, something that really, like Guru mentioned, is something that will come very handy. So coming to the principles of surgery in spine trauma, I think the principles of surgery remain like any other thing.
Vishal?
Yes.
When you ask a question to Neeraj, which is a case where you have to go anterior, what is your answer to that?
My answer?
Yes.
Lumbar spine, anything below L2. When I have a burst fracture, I have to do a corpectomy with two discs above, below, and a single vertebrae. I would want to use a bigger footprint of the cage with a lot of graft there and save the segments also without having to do a long segment fusion. So I would do only anterior fixation with a broad cage and preferably do a plate cage construct there without having the need to actually do a posterior long segment instrumentation.
Perfect answer. So all the points are there. I think you should emphasize that lumbar spine, where you want to preserve the mobility, where you want to go more than two end plates. Now we heard Amit say that expandable cage in lumbar spine has got limitations. The access to the anterior column from the back may be limited. So those cases where you have got upper and lower end plate damage, you have to go anterior.
Exactly.
You can choose lateral access or anterior access. That's your choice. But that is the case. That is very, very valid point, which has to be emphasized. That's when you have to go anterior.
I think all these points what Ranjit, Guru, Neeraj, and Amit and Umesh have mentioned here are all only highlighting one slide of this talk is principles of surgery. At the end of the surgery, intraoperatively, you have to ascertain that you have attained bone-on-bone contact. If you have not had a bone-on-bone contact either with the use of your cages or with the help of your bone graft, your implant is bound to fail. No matter how good a construct posteriorly you put across, how long you put across, it is bound to fail. So principle number one, at the end of the surgery, you should have achieved bone-on-bone contact. Number two, you should have achieved adequate and immediate stability. Like Guru emphasized, if you are doing a surgery for a patient with spinal trauma, it is your duty and a willful right of the patient to be mobilized the second day. And for that, adequate and immediate stability with the help of your implant construct is absolutely mandatory. Three, in lumbar spine, forget about lumbar spine. Every part of spine is important, is adding to mobility, and that is why saving and preserving level is absolutely important. However, optimal fixation, whether 2 level above below or 1 level above below, like we discussed, has to be also managed like we have just discussed this afternoon. Decompress when and when not, we are going to discuss about it very soon now. I think anterior surgeries versus posterior surgery, this debate was a debate in the primitive era. Today, there is no debate about it because posterior approaches are far better than anterior approaches, not only because of the ease and being conventional ones, but also because they can achieve same amount of decompression, same amount of reconstruction, and even better fixation using the tri-column fixation of pedicle screw constructs. And that is why posterior surgery remains the mainstay. Posterior surgery also is the mainstay in patients where emergency surgery is required. Like in a patient with fracture dislocation, you have to do a posterior surgery, and all the aims of clearance, canal clearance, kyphosis correction, reconstruction, bone-on-bone contact can be achieved posteriorly better than anteriorly. It is technically easier, has low morbidity. You can achieve almost same level of canal clearance like in anterior surgery. And of course, indirect correction of kyphosis is better and equally good than a direct kyphosis correction. However, in anterior surgery, the aim of surgery, which is canal clearance, of course, is direct and complete, and you can have a better kyphosis correction in an acute trauma setting. So these advantages cannot be taken away from anterior surgery, and they come really handy in specific situations like we just discussed a while ago. As I said, posterior surgery is the mainstay in patients with dislocation like type C3 injuries, because in these situations, you have to do long segment, you have to reduce the fracture. A reduction of a fracture dislocation is almost impossible. Doing it anteriorly, it is just not possible, and that's why it remains a mainstay in patients with type C injuries. In type C injuries, please do a first stage posterior surgery and only then plan, if required, an anterior surgery in these patients. MIS is also coming handy to you. Now the question comes, why go anterior at all in any of the patients if posterior is so well? We just discussed that vertebrectomies and direct cord compressions, reconstructions, particularly in lumbar spine, is something that really comes very handy. Like in this particular situation, and anterior surgeries help you to have short segment fixations. If you do a very nice anterior reconstruction, you can actually avoid doing a long reconstruction from behind. That's when it comes handy. And the other areas where you can do a short segment instrumentation is wherever the PLC is injured at bony levels. Like we have two types of chance fractures, bony chance fractures versus a soft tissue chance fracture. In bony chance fracture, you can do a short segment construct 1 level above below. In a stable burst fracture with incomplete neurology, again, only 1 level above below is good enough. And short segment is possible when you do an anterior reconstruction, either by anterior approach or by extensile posterior approaches like Umesh just mentioned. The most controversial, decompression, whether to do or not. So Neeraj, when do you add decompression? When do you avoid decompression? Like it is said that decompression doesn't add any value in a patient with complete neurology.
Well, my indications are absolutely clear about it. If patient is having intact neurology, normal neurology, then I would not open lamina. I mean, whatever may be the retropulse fragment, if it is a normal neurology, I will not decompress. And if
Ranjit,
it is an incomplete neurology, I will always decompress.
So Ranjit, it is said that neurology improves with canal clearance, and surgery should do canal clearance in all cases, irrespective whether it is complete or incomplete. True or false? What do you follow?
False. Clearance of canal compromise is not directly proportional to neurological recovery. It is not proportional.
Very valid point. Guru, in your practice, whenever you do surgery in complete paraplegics, do you routinely add? I mean, it's a common saying कि नुकसान क्या है यार, decompress कर दो ना. What is the harm in opening up the canal and decompressing it, even in a patient with complete paraplegia?
Vishal, actually, practically in most of the complete neurological deficits, we don't decompress.
So you do not
But then
decompress.
periodic, we don't decompress. We don't decompress, but it is for the base.
Amit,
But then
Amit,
it's
have
very
you
controversial topic. It's a very,
Right.
it's a
Yes,
very controversial topic.
Amit, let me pull you
Uh,
into this controversial topic. Do you believe in spontaneous clearance of the retropulse fragment? Is it a known fact or it's just a myth?
Yeah, it happens, but if I'm doing a surgery, so we have two scenarios. Patient has no deficit, we don't need decompression. But if the patient has deficit, then I would like to give the cord full chance. I would not like to wait for the fragment to kind of remodel to give the canal clearance. Secondly, patient may not recover completely, but tomorrow patient does another MRI or CT, and there is some compression still left behind. So I would not like to face that kind of situation that this
So
this
you
compression
are
could have been
worried
removed.
medico-legally than clinically to clear the canal, and in all cases you would want to clear?
Yes. If I'm doing a
Umesh,
surgery in a deficit, whether partial or complete, I'll definitely be decompressing.
Umesh, would you like to contradict this fact or want to supplement this?
Well, see, if we are dealing with a neurological deficit, so I don't think there is any reason why we should be discussing that decompression is not required. See, because the patient is undergoing a surgery after a for a trauma, and of course, even though the main idea of this surgery is stabilization, ultimately the reason why we have selected this surgery, as we have discussed in the initial portion of the discussion, that it is a neurological deficit. So, and the more the space for the is available for the spinal cord or for the nerves, better the chances of recovery. So
Umesh, however, Umesh, I would like to draw your attention to this one slide where a big study, almost 1,100 patients.
I'll come to that flexible. I'll come to that whiplash kind of a situation where the injury has happened and it has already decompressed by the time the patient has come to the position. But we are talking about a scenario where there is still evident compression on an MRI. So if we are not finding any compression on an MRI, of course, obviously there is no point in talking about a decompression procedure. But we are talking about a case where, yes, compression is still present, but maybe the compression was significantly more at the time of impact, at the time of injury, and now it has partially decompressed. And we are assuming that this amount of partial decompression that has happened after the traumatic impact is sufficient enough for the cord or the nerves to recover. So when, of course, if we are not doing any kind of a surgery, probably this would make for a valid discussion. But I think when we are doing a surgical procedure, and if the patient has an incomplete or a complete neurological deficit, and we don't know what are the chances of this patient's recovery, even if the injury is complete. So we have seen that patients recover from spinal shock.
I think I'll take up the points from
Vishal.
Yes,
I'll put it this way. Why not to decompress?
Why not to decompress? Yes, it's a valid point, Guru. And
can I answer?
Yes, Guru.
Can
please.
I answer?
Yes, Guru.
Why not? See, when it comes to especially spinal cord injury, there is something called as physiological instability to the cord. By decompressing a spinal cord immediately after injury, we are increasing the secondary injury insult to the spinal cord. That is called as physiological instability. And there are enough papers that a decompression can harm rather than benefit. So that is why I said
I would agree, Guru. I would agree that for where those points of discussion are mainly for the cervical spine. But I think when there is an anterior column injury in the thoracic or a lumbar spine, and if we are doing a procedure posterolateral or an lateral, so there are chances of injury to the chances of an iatrogenic injury while doing a decompression procedure is, of course, there will be some amount of handling that is invariably required. But if you are worried that this amount of handling is going to worsen any kind of an impact that it has on the
not handling, not
So
handling.
let me take this forward.
It is not handling.
I think this is that the whole reason of keeping canal clearance and decompression at the last few slides is because this is the most contentious topic to which there is absolutely no consensus even till today. There are no objective guidelines on when to decompress, when not. Yes, there have been some principles laid down saying that neurology may or may not improve by canal clearance in patients with complete injury. However, in incomplete neurology, it is said that clearance of canal is absolutely mandatory and it is directly linked to improvement of neurological deficit when it is about incomplete injuries. However, any form of surgery will improve neurology in complete injury. There is no clear evidence. So in those situations, whether canal clearance is done or not, there are papers to support and refute both sides of the schools. It is noted that spontaneous clearance, spontaneous resolution of the retropulse fragment will happen within 12 months by more than 70% if you do not disturb it. By disturbing the natural physiological environment, you may actually prevent natural resorption. The epidural veins disturbance can not only lead to creating an environment for further damage to the cord, but also will prevent spontaneous resolution in future also. And that is why there are cons for not doing canal clearance in complete neurology. Adequate clearance, if required, can easily be done by posterior surgery. However, the question always remains whether it will really improve the neurological outcome. There are further questions about whether clearance of canal results into enhancement or worsening of neurology at all or not. So now there is some objectification based on two large meta-analysis that motor improvement by at least one MRC grade does happen if you clear the canal in patients where canal is encroached by more than 50%. However, if the canal is encroached by less than 50%, spontaneous canal clearance should be left over to nature. And the only guidelines that is available now is that in complete neurology, always do canal clearance. Documented progression neurology, always do canal clearance. Whenever there is more than 60% canal compromise, always do canal clearance. For all other cases, you really don't have to do decompression or canal clearance. However, whenever you do decompression, there is always a disclaimer: neurology may or may not improve. It is not attributed to your canal clearance. So surgical decompression is not directly resulting into any neurological improvement in any of these patients. I hope all our panelists would agree to this. If any difference, we will take a quick comment before we just go on to the last slide there.
I would still decompress.
I totally agree. I totally agree.
Now, before we just go to the carry-on message, I think one slide that all the faculty and panelists have emphasized right from beginning is to differentiate a complete neurology from an incomplete neurology. I think this is the basic of trauma evaluation. Apart from the modern gadgets to evaluate the posterior ligamentous complex and also CT scans to evaluate the comminution of fracture, deciding and giving you answer when to do surgery, I think the one and the most important question is whether this patient has a complete neurology or an incomplete neurology has to be established right at the first point of contact, whether it is on the side of injury or it is in the examination room of emergency. All these tests to ascertain whether this is a complete neurological injury versus an incomplete neurological injury has to be done. And let us all promise to ourselves that all these patients deserve at least this much, because this small examination can change the whole course of neurological recovery in these patients, because even a subtlest finding can tell you that this is not a complete. All the legs, all the motor power in the legs may be zero, but a slight perianal sensation being present is a sign that this patient will surely improve significantly and may have functional recovery if you really rush into them and do a middle of night surgery in these patients. So this is one thing I would say that carry home from here. Role of methylprednisolone, we all know it is controversial. There are various modules of giving it, and there are various ways of giving it. However, it is still controversial. Nobody knows. In fact, there are studies to say that there can be harm by giving methylprednisolone in acute setting. Dr. Guru and ISIC have done some studies. These slides come from them as well. So I would leave that contention topic from any discussion here. To conclude, we have spinal trauma. We are going to have it even more often with this increasing world. As soon as the corona breakout happens and the lockout is opened up, we will see more spinal trauma coming up to you. And more questions that will rise in your minds. The answers to them are all present there in bits and pieces. And I hope that this webinar, in presence of all these experts, friends of mine from ASSI, we hope that we have been able to come up with some conclusion through these classification systems on various questions. So go through these classification systems, validate them in their own study. The two most important things that have happened in the last decade is giving due emphasis to PLC and detailing the pointing of the neurological injury, and of course determining the timing of surgery in these patients. And I'm sure with this we all would leave this webinar intelligent and wise enough to deal with them in a more prompt way. Thank you so much, guys. We're open to question answers. All the panelists answering the questions there.
Vishal,
Quick comment, Ranjit.
Yeah, just one point on. So with all these things, we realize that we have to score every patient, what we see. So
True.
I have just one suggestion. So all the participants who are not familiar, you can go to www.spinescores.org. Spinescores.org. There's a very nice app called Spine Scores. So if you can,
Spinescore.org.
yeah. So can I share my screen?
Please, please. Sai,
So
allow Ranjit to share the screen, please.
Yes, yes.
So can
Ranjit, you have lost weight, huh?
so can you see my screen?
Yes, we can.
Ranjit could get a chance to get a haircut.
Yeah, सब कुछ बंद हो गया इसलिए. Can you see the screen?
Yes, we can. We can see you. You will have to share your screen.
Oh, I think I have I not shared my screen.
There is a green button down with an arrow.
Yeah, okay.
Upward
okay,
arrow.
okay.
Yeah, now it is. Now it's there.
So can you see the screen? So go to this app. Can you see this Spine Score?
Yes, we can see.
We can see that now.
Yeah, please. This is a very good app. It has got infection, trauma, myelopathy, tumor, both Android as well as iOS. It's very, very handy. If you just go and download it, go through it, it makes life very easy. I think it's a must-have. It's a free app. It's a free app. You know, so you go to start, go to trauma. You can see step by step how to go with the TLICS as well as the load sharing score. So it helps us in three common things what we see in an ER: trauma, infection, myelopathy, tumor. Essentially everything ending up with neurology. That's all, Vishal.
Perfect. I think there is a question from Dr. Apur Acharya. He's asked about, when in doubt of confirmation of canal clearance by indirect decompression, we can confirm using a epidural dye and intraoperative imaging to sacrifice removal of bone, which may be important. So any comments on that, please? Use of epidural dye after indirect decompression to ascertain whether direct decompression is required or not.
Indirect decompression, how? Means,
by just positioning the patient and compressing or distraction.
Okay.
Any role of dye?
So I tried it a couple of times, but the problem is that for the dye to reach anteriorly, it's very difficult, you know. So I didn't find this method very reliable to be true.
No,
so
I guess, you know,
we have never done it. And
I was done. And secondly, I think, you know, when we are already talking that canal clearance has no actual role in neurological recovery, you know, there are so many studies which actually says, I think, you know, I mean, confirming a decompression is something which is not required. And what I mean by decompression is, you know, I mean, maybe just doing a laminectomy, you know, I mean, not try to push too much, not try to reconstruct anterior too much. You know, I think you should not disturb the epidural environment too much while decompressing. So I think, you know, putting dye and everything, personally, I'm not a fan of it.
So I think Apur, I think any further questions, Apur, please don't hesitate. All the participants, they can unmute and ask a question. We will be more than happy to take any questions forward. There is another question from delegate Dr. Kushal Gohil has put up a question. Role of cement in acute setting in fractures.
Well, I guess, you know, Guru, that's entirely a new topic, you know, I mean, whether you want to do in a geriatric compression, osteoporotic fracture.
No, we are talking about, this is not about osteoporotic fractures, role of cement in thoracolumbar fractures.
No role.
No, don't think so.
I think
No
there is
role.
absolutely no role. My personal take is, of course, there are studies like Kushal has raised a very valid point, because there are studies where cement has been used in patients with very bad load sharing classification to reconstruct that fractured segment, and then stabilization with instrumentation has been recommended. There are these case reports with small case cohorts. Long-term studies are yet to come. However, the contentious issues here is use of cement in young patients in acute setting where it is very vascular, plus end plates are fractured. So the leakage of cement can be really detrimental. And so there is a big concern about use of cement in these acute fractures. Yes, Guru.
Vishal, there is a in younger patients there is a role of calcium phosphate cement, not the silicate one. The calcium phosphate, which ultimately turns into bone, it can be used along with the fixation, but not the usual VTP cement.
I hope the answer
calcium
is clear.
phosphate is, and the
Vishal,
calcium
I think you
phosphate is
also
not
put
strong. Calcium phosphate is not strong enough to itself. Doing a VTP is vertebroplasty is not enough. With the fixation, you can use calcium phosphate in younger patients, but not the usual VTP cement.
I think I would still little disagree on this, that use of cement in acute thoracolumbar trauma setting with end plate fractures where the fracture has end plate injuries. My personal feeling, there are articles there. However, I personally would refrain from using any kind of cement, even if it means stabilizing it with percutaneous fixation, supplementing it. I have a little concern from my side about the leakage of cement, and also in young patients, you just reconstruct them, do a transpedicular grafting in them. It is more than enough, and stabilize them. That is really going to help instead of using any cement in these patients. I think that's a better option.
Just as an extension, can we just as an extension, Guru, what would be the indication for using cement in these cases? Like, would you use it in a case where actually an anterior reconstruction is required, or would you use it in a case where you know?
So basically, you are doing an
I think Umesh, the principle when it was promoted was the same, that in a patient where you have high indicators of pseudoarthrosis, when you know that these patients are going to
anterior collapse.
Yeah, when anterior collapse is bound to happen, in those patients with an interfragmentary screw with posterior fixation, you use a calcium phosphate cement. That was propagated. However, there are follow-up studies available already showing implant loosening happening in them also, and strong propagation of that concept is already fading away. So I think use of cement in acute setting is not what is strongly recommended. I'm still not aware about a strict indication when that is going to be more better used.
One indication would come to my mind is, maybe when I'm dealing with an acute traumatic event in a geriatric patient, where you don't require actually the anterior reconstruction. You only want to do a posterior, but the bone quality sometimes is so poor that you are not very sure that whether this will heal or not. In those cases, maybe putting anterior cement might help. Otherwise, I don't think that cementing is a good option in acute trauma setting.
Right. Is there a way we can share? Is there a way where we can share articles here right now before leaving, or no?
Vishal, there is a file on the right lower corner. You will see a file button.
File option
below the chat. File option below the chat.
Okay.
Where you type
so you click on that and you can share anything from your computer.
More. Yeah, share file in the meeting.
Yes.
So I can do that. Now there is a question while I'm doing this. There is another question that is coming up. The question is role of transpedicular bone grafting. Ranjit, would you want to take that? Role of transpedicular bone grafting?
It actually was very popular from the Japanese school of thought. I'm not really convinced that how much can I really transpedicularly fill up the defect from the back itself. I used to do it earlier. I seldom do it after the screw came in. At the index level screw came in, I seldom do any transpedicular bone grafting.
I think again the topic here is that transpedicular bone grafting is required only in patients where you feel that this is not going to heal. However, if it is not going to heal, only transpedicular bone grafting in geriatric population has known to be failing mechanically, and that is why when load sharing classification is in favor of anterior reconstruction, please do not supplement that only by doing a transpedicular bone grafting. You are bound to have a failure there. These principles apply very, very stringently, that anterior reconstruction means anterior reconstruction. You cannot bypass that by just doing a transpedicular bone grafting. It doesn't work that way, at least in young patients. By short segment instrumentation, it is bound to fail. Another question.
I have a question. If
Yes,
I can
please.
ask. Yeah. So
Please.
I think we had a good discussion about overall management of spinal fractures, especially in the thoracolumbar region. So this question is about the management before your patient goes into theater. Yeah. So it is about the spinal precautions, to be precise. So when you get a call from your resident or your junior informing this particular patient with type B or type C with intact or progressive neurology is admitted under you, how do you instruct your juniors or the nursing staff or the theater staff to handle the patient in order to make sure that spinal precautions are ensured and no further damage is done because of handling? Now, I think why I'm asking this is because I had to attend a court meeting a few months back where I was supposed to answer why spinal precautions were not ensured, including the ambulance crew who were called to explain why they did not ensure spinal precautions for an ankylosing spondylitis patient who had thoracolumbar fracture. So I have worked in Sion Hospital for a substantial period of time. I have seen how it works in government, in corporate hospitals in Mumbai. I believe our staff in the theater, nursing ward are not much well versed with ensuring spinal precautions. If the nurse wants to change sheets for whatever reason, or when the theater staff shifts the patient from trolley to the operating table, do you as panel members make anything how do you make sure that spinal precautions are ensured?
Ranjit, would you like to take that question? The technique of mobilizing a patient from bed to trolley to operative table. I think Ranjit and Guru, you both have vast experience having worked in spinal trauma units for a very long time. We would like to have your word on that. What are the precautions to be taken while shifting a patient with no neurology or incomplete neurology from one place to another till stabilization comes across?
Okay, number one, there is no difference between no neurology, incomplete neurology, or intact neurology. All have to be handled the same way. Number one. Number two, it is very much like the ATLS protocol. It is strict. So in our setting, the ambulance, right from the ambulance retrieval, it's standard. Every patient goes on a spine board. Every patient has got a cervical collar put in. It might not be a really well-fitting collar, but it is strictly every patient from the ER reception goes under the spine board, suspected spine trauma. Even every polytrauma goes on the spine board, because we don't know when the polytrauma comes in, is it there is spine injury or not, especially if you got a spine fracture plus limb fracture. So patient is received on the spine board. The patient goes to all the imaging on the spine board. So in my hospital, unless the spine surgeon clears, the spine board is not removed. So we have situations where we have had pressure sores because the spine was not cleared. So that is it. It has a strict protocol, like what the doctor said right now. It's not infrequent to be called to court to answer why did this patient develop secondary injury, especially if there's a doctor advice in the team. I've faced it. Angspon patient, generally they come with no deficit. You handle them, they get deficit. This is one situation where I go in for urgent surgery, which what Vishal asked and what Dr. Neeraj mentioned. Progressive deficit, most common in my setting is Angspon or dish patients with a fracture. We handle them, they develop deficit. Might not be a myelopathy, even a radiculopathy. They develop limb or arm pain or numbness. It means while handling, there is some kind of translation happen and the foramen is been compromised. You develop symptoms. This patient requires early realignment, and ECS for us is surgical realignment. So that is it. Protocol-based following.
Thank you, Ranjit. Wonderful elaboration of way a patient should be handled, and there is absolutely no difference in any patient with spine trauma of any location. You have to strictly follow that. Guru, one quick thing you would want to add to this, or you just agree to this and stop there? Guru Raj, Any addition to this in your way of handling the patients? Transfer of patient from one place to another? Like any board, any brace that you use, or a specific guidance or supervision that you follow? I think Guru is not able to hear us. Any
No,
further-
I heard just now, Vishal.
Yeah.
The other thing is log rolling of these patients. Spine board is very important. The other thing is log rolling of these patients. Like you need minimum 3. The ideal is 4 people for log rolling.
So minimum
Are you
3
able to hear
people
me?
for log rolling. That is absolutely mandatory. It is mentioned in all spine trauma guidelines. Minimum 3 people required
Yes.
for log rolling. Any less will lead to a twisting or shearing injury.
4 is ideal.
And that is what should be avoided. One last question
4
about
is ideal.
Yeah. One last question before we close down. Thromboprophylaxis in these patients. Guru, in your center, what is the role of thromboprophylaxis, heparin or any other modality that you've been using in acute setting, in
Yeah.
post-operative setting, and in chronic setting?
So we are using low molecular weight heparins for all of them. All the spinal cord injured, for pre-operatively, intraoperatively, and post-operatively minimum of 6 weeks. Even though it has been found that in Indian population, DVT, the incidence of DVT is less, but then still we keep on seeing DVTs post-operatively. So minimum of 6 weeks post-operatively, we continue LMWH, and pre-operatively we do start them, and we don't stop them before surgery or after surgery.
So I think this is one of the experiences that Dr. Guru mentioned. There are papers to mention about role of oral anticoagulants also in trauma patients. There are other modalities of anticoagulation also, and then there is a controversial paper also about the incidence of DVT in Indian population with patients of complete paraplegia, which mentions that the incidence is far lower, and there is a controversy still happening there. However, the biggest center, ISIC, has been following this protocol, which you just heard from Guru.
One thing is very important. The other one thing is very important. We have to always keep an eye on the blood pressure. We
Right.
shouldn't allow the blood pressures to go down certain minimal systolic at least, or a MAP, because that is very important.
Perfect. I think we have had our day. We are here for last 1 hour and little over than 30 minutes. And I'm sure we have had a wonderful session on spine trauma, one of the most controversial topic. Anything from any delegate who would want to come and talk one-on-one with faculty, they are more than welcome. I'll be sharing the email IDs and phone numbers of, yes, Apur. Apur, do you have a comment to make? Apur Acharya? No, I think.
Good evening.
Hi, please, Deepak.
Yes, sir. So, is there any benefit of the indirect ligamento-taxis in the decompression in the thoracolumbar fracture? Indirect decompression or ligamento-taxis benefit?
Amit, would you want to take that question? The role of indirect ligamento-taxics, the moment patient is positioned, or compression distraction maneuvers to create indirect ligamento-taxis in decompression.
The one thing which we very commonly see, as soon as you position the patient prone on the bolsters, the spine opens up anteriorly. So I think half the job is done over there. Sometimes we go with great planning, we'll do this maneuver or that maneuver, but as soon as you position the patient, half the job is done. So the benefit is that your direct decompression will be reduced if the indirect decompression has been achieved. So one way you can do it, rather than keeping a bolster vertical, you can keep them horizontal. You can keep them horizontal, one under the chest and the other one under the both anti-iliac, just under the pelvis. So this will put your middle part of the spine in lordosis, and that will open up the thing anteriorly, and it will reduce the posteriorly migrated fragment anteriorly. So that's a trick, and advantage is obviously that your direct decompression will be reduced and maybe avoided if you have achieved enough ligamento-taxis and your fragment is totally away from the anterior part of the spinal cord. Then your job is done. You have to just instrument and do the fusion.
I think thank you Amit for bringing a valid point of how to position these patients intraoperatively. I'm sure there are going to be multiple and many more controversial issues in topic of spinal trauma to be discussed. Non-fusion surgeries, role of cementing, role of bone grafting, when to not do grafts, when to do short segment instruments, interfragmentary screws, and various other topics. And I'm sure all these topics will require further deliberation on multiple such forums. But for now, I'm sure we have all got many more important things to do than on this webinar. And I'm sure in coming days, we'll be discussing many more other topics in the same manner that we did today. Before we sum up, I would like to thank all the participants for being around, raising some really valid questions around, which have been really intriguing. And I'm sure many of these questions were such that answers to them in an objective manner were missing even from the most experts' minds. I thank you all for being around. Thank you, Amit. Thank you, Neeraj, Guru, Ranjit, and Umesh. Thank you for being around. I could see Ayush Sharma there silently, being there and contributing directly and indirectly by being around with us. Thank you, everyone, for being around. And I'm sure we'll have a better session tomorrow. Thank you, Ayush.
Thank you all.
Ayush, tomorrow you're going to be there for our symposium in active manner.
Yeah, hopefully. I was just listening. It was great listening to you guys. I learned so much.
So from Bombay Spine Society and from ACSI, I would like to take a leave from you. Thank you so much. We'll come back to you tomorrow, sharp 4:45. The timetable will be shared to you on the forum again. Thank you, panelists. Thank you, delegates. Thank you again.
Thank you, everyone.
Good one.
Bye, guys.
Good to see you all. Yeah.
Hello.